thank you to the Maryland Coalition of Families and Carol Lenza for inviting me to present, and thank you to Adam for your assistance with the technical difficulties. I'm going to, as Carol said, I'm going to try to end my part of the presentation by 12:45 so that everyone has time to ask me questions. So to talk about mental health and substance use disorder parity, what is it, what does it mean? And then I'm going to talk a little bit about the Affordable Care Act, and then kind of wrap up with what are your rights when it comes to health insurance and accessing treatment under health insurance, and how to file appeals and complaints, and then take your questions. So the Mental Health Parity and Addiction Equity Act was a federal law that was 2008 and became effective in October of 2009. And as with any federal law, they can't really be enforced without regulations. And so we got our first set of regulations to enforce the law in July of 2010, and we are still waiting for our final regulations. But the current regulations, the interim regulations, do have the full force of law. So this law is fully in effect, and are required to abide by it. The goal of the law was to ensure coverage that provide coverage for mental health and substance use disorder is on par or equal to coverage for physical or medical illnesses. The goal was to remove the historical discrimination that people have experienced when they try to access health or addiction treatment through their health insurance. That's really that last bullet there you see on your screen. If mental health and substance use disorder treatment is covered by your insurance company, then the treatment limitations and the financial requirements they have can't be different or more restrictive than what you have for your medical and surgical benefits. The whole concept of parity, it's a law based on comparability. So unfortunately, not all insurance companies or insurers are covered under the law in 2008 and currently. The good news is that all large employer insurances are covered. So if you are employed by a company that has been 51 or more employees, then your insurance company is required to abide by this federal law. If you are by a small employer and get your health insurance from your small employer, then they are not required at this time to abide by the mental health parity law. But in 2014, when the Affordable Care Act was in effect and the small employers have to provide the essential health benefits package, they will have to abide by parity, which is the same for individual and self-employed plans. And those plans that if you purchase them yourself, so if you don't get your health insurance from your employer, or if you're self-employed and you have to go to a broker or you go online and buy your own health insurance, currently they're not required to abide by parity, but in 2014 they will have to. If you're an employee, federal, state, or local, those are covered under the federal parity law at this time. Specifically about the law, it is not a mandate for coverage, unfortunately. It does not require that a plan provide mental health and addiction treatment. But if a plan does provide it, then they have to be comparable, then the benefits have to be comparable to those benefits for physical illnesses. It does not address the type of diagnosis, conditions, or disorders that are covered. Plans can decide which illnesses they're going to cover and which illnesses they're not going to cover. The good news is, though, is that the majority of large employer plans do provide some level of mental health or addiction treatment, and as long as they provide any level of coverage, mental health or addiction treatment, that you provide it at parity with coverage for physical illnesses. So the good, most large employers already are providing the coverage, and because they are, then they have to expand parity to health and addiction coverage. And in Maryland, some employer plans have to cover mental health and addiction, have to cover mental health treatment in the comprehensive standard health benefit plan. In 2014, all individual and small employer plans will be required to offer mental health and substance use disorder benefits because they are required to offer the essential health benefits package. And categories is mental health and substance use disorder at Parity. The law hinges on two comparability between two different things: financial requirements and treatment limitations. Financial requirements are we all have to pay whenever we go to the doctor, things like co-payments or co-insurance, whatever your percentage is, your deductibles, and then the time limits. And the list that any of the requirements or treatment limitations can be more restrictive than the dominant financial requirement for substantial all the medical surgical benefits. So that's the comparability threshold there. If I'm not going to go into the specific math formula that's required by the law, but if someone has a specific question about that, I'm happy to take that at the end. Treatment is the other way that plans limit your access to different treatments. And plans break these down into two different types of limitations. The quantitative treatment limitations are the ones that are expressed numerically. So it is the number of visits that you're allowed to see your psychiatrist per year, the number of days that you're allowed to stay inpatient in a hospital, or the number of days you're allowed to partial hospitalization coverage. Those are all quantitative treatment limits. There's a specific that has to be done in order for plans to show that they're compliant with Parity law for these treatment limitations. They have more restrictive treatment limitations for mental health than they do for physical health in order to comply with the law. So they can't say you can have unlimited inpatient days at a hospital for your first procedures, and then allow you 5 or 7 days for mental health. That would be considered non-compliant with the law. That plans limit people's access to treatment is by what's called non-quantitative treatment limits, and that really is just a fancy word for saying can't be expressed numerically. So there's no numbers involved with the non-quantitative, but these are usually care management strategies. So the utilization review their plan has in place in order to determine whether or not a type of treatment is considered medically necessary, whether or not prioritization requirements. So if you have to call and get authorization before you're out a certain type of service, often this happens with inpatient treatment, sometimes also with outpatient treatment. That plans set drug formularies and how they decide which are preferred drugs and which are non-preferred drugs. Often what happens, one of the treatment limitations on the for addiction is a fail first requirement, where insurers will require a patient to fail at a lower level of treatment. So they may require that before you qualify for real substance use disorder treatment, you have to fail at patient treatment, or you have to have tried therapy first. If they don't have that same type of requirements for the medical and surgical treatment, those type of fail first procedures, then they're not allowed to have them for the substance use disorder or the mental health treatment. Unfortunately, there is no numeric way to express these limitations. There's no easy math formula that is used, and so the law simply states that any of these medical management standards, the PSEs and the criteria that they use, have to be comparable, and it can't be more stringently applied. So they have much more stringent medical necessity criteria for mental health treatment than they do for your physical treatment. Medicare is exempted from the federal parity law. The feds decided that it would cost them too much money to make Medicare parity compliant, and so they specifically exempted it in the law. The good is that Medicare, there was a bill passed in 2008, a parity bill was passed called the Medicare Improvement for Patients and Providers Act, and it was kind of an omnibus bill, and it had a lot of different protections in it. One of the things it did have was a vision for outpatient mental health parity. So for co-payments and visit limits. And so currently, we're at the 60% threshold. So currently, as of January 2012, Medicare would pay 60% of your outpatient cost to seek mental health treatment, mental health or addiction treatment, and then Medicare recipients had to pay 40%. And 2014, by January 2014, they have that on par with what is happening on the medical side. So in January 2014, Medicare will pay 80% of your outpatient costs for mental health and addiction treatment, and you'll pay 20% if you're a Medicare recipient, just like what is already provided for the medical for medical patients. So currently, Medicare recipients only pay 20% to see outpatient medical practitioner or to see their doctor. They only pay 20%, but we're currently paying 40% to see outpatient mental health provider. Medicaid and Parity. For Medicare and Medicaid services issued guidance in 2010 that said that the MCO plans had to be Parity compliant, which was great, except that they did issue any specific guidance. And as some may know, Medicaid is very different in all of the different states. So some have mental health and addiction rolled right into the MCO, therefore easier to determine Parity compliance because it's based on comparability. But some states like Maryland who operate on a carve-out system and without more specific guidance on how the state would ensure parity, it's really difficult to hold anyone accountable in a carve-out model. But more good news is that in 2014, when the Medicaid expansion goes into effect, which I'm going to talk a little bit about in a second, that person has to receive a Parity compliant plan. So they seems to be voicing intent that all Medicaid plans will be Parity compliant. We're just waiting for them to give us the guidance on how to make that happen. And for anyone who's involved in the behavioral health integration process here in Maryland, a report issued, and in that report, the state gives it to bring Maryland Medicaid in compliance with Parity. So we just have to assist them in making it happen. So a little about the Medicaid expansion. We're lucky, those of you on the call that are Maryland residents, that our state has decided to take the government up on its offer of a more robust federal match for Medicaid for adults up to 133%, which in logistics actually works out to be 138% of poverty because the federal government has doesn't look first 5% of income. So in 2014, Maryland childless adults who have 139% of poverty will qualify for the Medicaid expansion. Currently, a lot of those individuals are enrolled in the primary adult care program, and in 2014, the primary adult care program, those recipients will just automatically become eligible for the Medicaid expansion and will become eligible for Medicaid. More news from Maryland is that the state had an option to provide a different benefit package to this new population, kind of like what we do in the PAC program. But Maryland decided, because of the federal match, the 100% federal match for this population, that they would provide the current Medicaid benefits to this population. So individuals that are currently on the PAC program and have a much more limited benefit package in 2014 will become eligible for Medicaid and will receive the current Medicaid package, which some of you may know has a robust mental health and addiction package benefits. So let's kind of talk a little bit more about the Affordable Care Act. I could talk about the Affordable Care Act, but I'm going to give a few highlights, and if people have questions, again, I can take more specific questions at the end. But the Affordable Care Act requires that smaller and individual plans provide the essential health benefits package. And that package, as I stated before, 1 of 10 categories is mental health and addiction treatment, and then it is provided at parity. Maryland, the states were allowed to choose their own essential health benefits package rather than HHS. The federal government decided that they weren't going to choose the plan that was right for all the states. They were going to let the states decide for themselves. So we implemented a stakeholder process and used the legislative and executive committee to decide and submit our benefit plan. And with a lot of work from the advocates and consumer advocates and provider advocates choosing the state employee plan as the benchmark. They had an option to choose an employer plan or a large employer plan or the largest HMO plan or federal employee plan or the state plan, and plan because they provided a full package with robust benefits. And we're working on this, advocated heavily for this because we felt that the state employee plan had a much more robust mental health and addiction package than the small employer plan, which is the plan many states chose is that small employer plan, and it has the most level of benefits. In 2014, actually in October of 2013, this health benefit exchange called the Maryland Health Connection will go live, and employers and individuals will be able to go online or go to a Navigator and purchase qualified health plans from the health benefit exchange. Individuals who are between 139% and 400% of federal poverty will qualify for different levels of tax credits and subsidies to enable them to afford to purchase this insurance. So Maryland has some pretty projections about how many people we're going to be able to bring into health insurance coverage. We're working really hard right now to try to implement some continuity of care requirements because individuals who are at 138% of poverty will qualify for a Medicaid benefit. Individuals who are at 139 or 140% of federal poverty will be in the exchange with a subsidy, but will purchase private insurance, which will have things like pays and will have different types of requirements that they may have not experienced when they were eligible for Medicaid. And so it's going to be really important to help these individuals transition into the insurance market. A little bit to why parity matter and why is it important to pass on 2008, and then recognition of parity's importance. The legislators, when they passed the Affordable Care Act, amplified parity by requiring the small employer and the individual to be in compliance with parity. So parity, as I said before, it addresses historical discrimination. It removes barriers to treatment. There are more onerous prior authorization requirements that be removed. If there are co-payments to access mental health treatment, those have to be removed. So it actually enables people to better access necessary treatment, and it recognition that mental health and addiction treatment are necessary for just as necessary for whole health as intended care and maternity care and primary care. And so I'll transition now into giving you kind of a background of the law to probably give you some understanding of what you can actually do if you are struggling with your health insurance to get access to the treatment that you need. So if you've been denied authorization for treatment, or if you've been denied reimbursement for treatment, or if you're not able to treatment, there's not a doctor who or not a psychiatrist in your area or on your insurance panel, what are your options? What can you do? What you can do is file an appeal, and it's when you receive a denial letter from your insurance company, they're required to give you a letter of a risk of denial and reason of denial, and on a written reason of denial, they to also give you information on how to file an appeal. has to give you the line, it has to give you the phone number and the address of how you can actually file the appeal. And in reality, filing an appeal is not as difficult as people may believe that it is. Often, partners are willing to work with consumers to file these appeals because they have a vested interest in getting paid themselves. And sometimes it's as simple. Sometimes an appeal is as simple as the provider refiling the complaint and refile the claim and highlight it's an appeal. Sometimes the consumer will write a letter themselves, just say that they're appealing the denial of treatment. It's important to note that in Maryland, 50% of appeals are actually overturned for the consumer. So, one chance of actually getting reimbursement or getting authorization or getting a few more authorized if you actually take the time to file an appeal. So I would highly recommend that if you do receive it now, that you go next step and file the appeal. You also file a complaint, and then of course we always welcome partners and family members and provide to help us advocate for Parity and advocate for adequate coverage in health insurance. About how you can file an appeal if you are insured by a private insurance company. So if you're not getting Medicaid or Medicare, which have different appeal requirements, these are some of the steps you can take. So the appeal, as I was talking about earlier, is really just the first level of appeal. You file directly with the insurance company. It really just kind of puts a red flag on your claim and says this person feels like they are to the next level of review. Often happens is it goes to a medical director or one step up from the manager who may have initially denied the treatment. So if you file the first level of appeal with your insurance company, if the insurer upholds their decision and upholds the denial, then you have a second level of appeal that you can use, which is called external appeal or external review. You can again file that with your insurer when you receive the of the decision. In that, they have to tell you what is the next level of appeal you can do and what are your deadlines. And I recommend to what I'm working with that if we second level of appeal, that we also file with the Maryland Insurance Administration at the same time. And the reason I recommend that is because the Maryland Insurance Administration carries a lot of weight, and so when they contact an insurer and they offer the information that's necessary and kind of expedite the external appeals process. What are types of appeal decisions? Like I said, if they deny you authorization or deny you reimbursement, you can appeal those decisions. If you believe there's a parity violation in the denial, so if one of the appeals that we've worked on here that I've assisted people with is if a insurance company is requiring a really prior authorization process, if they're requiring a treatment plan after 5 visits and only approving 2 or 3 or 5 visits at a time, and then having to file a new treatment plan, and so psychiatrists are requested to do a telephone call to utility review agent for or more, essentially a parity violation, because that same level of authorization is not, same level of difficult, not required in other authorization processes on the medical side. And so we've appealed authorization denials of the authorization process being a violation of parity. The appealable decision that many people don't know about is inadequate network. So we know that there are a shortage of child psychiatrists in Maryland, especially those who accept health insurance. And so if you are unable to get an appointment for your child with a child psychiatrist in a reasonable time, without reasonable delay and with reasonable distance from your home, you have a right to access out-of-network care. So you have a right to force your insurance company to pay for you to see a psychiatrist that may not be a part of the panel. In order to do that, you have to file an appeal with the Maryland Insurance Administration and show that there is a lack of psychiatrists on your panel. We know happens on a lot of insurance panels, but most people don't know that they actually can appeal the decision, be able to get reimbursement for seeking out-of-network care because they were able to actually access the care that they needed in network. I can tell you all of these things that you can do to appeal and to get reimbursement and to get authorization for treatment, knowing that most don't have the time or the energy or the wherewithal to complete the paperwork necessary. And so one of the things that I do here at my job, the Maryland Parity Project, is assist people with appeals. So if you've been denied authorization or if you've been denied reimbursement, my contact number and email was on the front slide, and you're going to see it again at the end. I would, feel free to call me. I'm happy to assist. I'm happy to actually file appeals for people, file complaints for people on behalf of consumers and providers, and would be happy to help. So the Maryland's Attorney General has a health education and advocacy unit, and received a denial letter for treatment. May have seen the Attorney General's unit number on the back of their denial form. They also will assist people with appeals. People are quite successful when they bring in the Attorney General's unit to assist with their appeals. And I have their contact information at the last slide as well. So all of this to say is that you do have rights, and there are people who can assist you in ensure that your rights are not violated. Those are a little bit different. If you are deal with Medicare directly, again, you will get denial from Medicare, and on that denial letter, they tell you there's an address for Medicare, or appeal with them. If you're filing an appeal directly with Medicare, they give you a decent amount of time, and it's the 90 days to file with Medicare. But where it gets confusing is that many people actually have a Medicare Advantage plan. And if it's a Medicare Advantage plan that's denied you, then you have to actually file your appeal directly with that plan itself. And you will have 60 days with the Medicare Advantage plan. And then if you're denied from your Advantage plan, you can ask for an independent review. And I didn't detail all of the detail for the Medicare appeals, but there are quite a few channels to use when you're appealing with Medicare. Once you start the process, they kind of walk you through and continue to appeal with Medicare. Those, again, so different. If you're appealing a decision by your managed care organization, one of the health choice managed those, then you need to appeal directly with whoever your MCO is. If you are, if it's behavioral health, we operate under the code here in Maryland. You get to appeal directly with Value Options. Good news is you actually have 180 days to file an appeal with Value Options. I would not recommend waiting that length of time. The quicker you start an appeal, the quicker you can get authorization for treatment, or you can get your reimbursement back. If you're unhappy with the decision, you can file a second level of appeal where it would go to a medical director in Value Options. The note there, though, that second level of appeal, you only have 10 days to actually file that. So they give you a long time to file the first appeal, and then they start shrinking those deadlines down. And if they uphold their decision, if the medical director upholds the first decision, then you can request an external review. I also always recommend to people to contact their core service agency in their area, and also Mental Health Administration will sometimes assist with these with appeals or with Value Options. Some grievances. So are a little different than the appeals. This is where you feel complaints are if you feel you've been unfairly treated or discriminated against. So network adequacy issues can be done through the complaints and grievance process. And this, what really separates the process is that it's done from the insurance company. You can find directly Maryland Insurance Administration for, like I was saying, for parity violations. If you believe your insurer has an inadequate network, if you believe that there are psychiatrists listed on the panel that are no longer taking new patients, or unable to find someone to provide outpatient treatment, then you can file a complaint directly with the Maryland Insurance Administration. Even if you've been denied treatment, you file a complaint or an appeal. Other discriminatory issues or billing issues, those can all go directly to the Maryland Insurance Administration. Unfortunately, the Maryland Insurance Administration doesn't have authority over all insurance plans. It only has authority over state-regulated plans. Large employers that self-insure are not subject to Maryland law. They're subject only to federal laws. And so those complaints have to go to the U.S. Department of Labor, Department of Health and Human Services. For parity complaints, they go to the U.S. Department of Labor. So insurance, for example, not calling anyone out here or saying anyone's non-compliant, but a lot of large employers in the state self-insure and therefore aren't regulated by the Maryland Insurance Administration. So your Northrop Grumman's or your Johns Hopkins and your large employers are regulated only by the federal government. And so the way you can tell how your plan is regulated, or a self-insured plan, or if you have a state-regulated plan, is to HR representative, whoever you work with when you in your health insurance, is the person who would know the answer to that question. You file a complaint against Medicare, you file directly with CMS, at Centers for Medicare and Medicaid Services. And if you have a complaint about Medicaid value options, you can file that with the Mental Hygiene Administration or the Department of Health and Mental Hygiene. This is my implement, the Maryland Parity Project. My job here at the Mental Health Association of Maryland is to, what I'm doing today, to talk to people about the Mental Health Parity and Addiction Act, as well as the Affordable Act. And then the fun job is to actually assist consumers and providers to file appeals and file complaints. So the number with my extension, we have a website which has a lot more detailed information than what I've given today. I also have a blog at marylandparity.org/stayinformed, which all of the different are happening around the Affordable Care Act and around the mental parity law here in Maryland. And you can contact me via email through the website as well. List of resources. Again, there's the Attorney General's Health Education Advocacy Unit. There's the website, on Insurance Administration website. I don't know if places are places where you can file appeals or grievances. It looks like I was actually able to finish 2 minutes before my scheduled time. I'm happy to take questions.
Point, we have a manageable amount of attendees, so I'm just going to unmute everybody, and if you have a question, go ahead and ask your question. So, be unmuted in a couple seconds. Okay, if you have one, please go ahead.
Looks like, hear me? Yeah, okay. I didn't know if I was unmuted. This is Carol. And so it looks like we may not have any questions, that you may have covered everybody's questions.
Not sure what that says about the presentation, Carol, if that's a good thing or, you know, if it's just too much information. But please, if anyone has any questions after, please contact me via email or by phone if you have specific healthcare reform or parity questions. I'm happy to answer them, or if something comes up later after the presentation.
And I think it's totally complex with the different types of insurance, and private insurance and self-insured and Medicaid and Medicare and Medicare Advantage. They certainly didn't make it simple.
Right, they don't.
The Affordable Care Act did not make it much simpler than what we had before to navigate, but it's really good, I think, about those navigators that health exchanges.
Right. I think that the navigators will play a role than just enrolling people in insurance. And so we're hoping, and we've been pushing that maybe we can employ some patient navigators so that they can actually help people navigate the complex system. And so it's no, people get nothing else out of today's webinar other than some resources that they can use when they're difficult with their health insurance. I'm happy with that as well.